Colleen Bayard, our Director of Regulatory and Clinical Compliance and our Education Coordinator. I want to welcome you to this discussion of the newest and latest operational challenges associated with the face-to-face regulation and the changes that went into effect on January 1st of this year. A couple of things I want to say before turning over the program to Colleen, who will walk through the presentation. As you all know too well on this call, this regulation not only affects us in home care, but also affects our hospital and physician partners. Maybe not in terms of payment as it affects us, but it certainly affects their operations. And we at the Home Care Alliance wanted to let you know that we've been doing all that we can to educate those partners to these changes. We have had 2 sessions now with committees at the Mass Hospital Association, and we have really focused our attentions in those committee discussions on making completion of the face-to-face part of the post-acute care transition best practice. And I think we've made some impressions on them how to incorporate this. While we are focused on compliance and not the politics of face-to-face today, I just want to say a couple of things around our significant efforts on the political and policy side to try to mitigate the problems associated with this rule. I mentioned we have engaged with the Mass Hospital Association on education. We have been working with the Mass Medical Society and organized physicians around advocacy to make CMS and the Congress understand that the sufficiency standard that they've set for documentation for physicians exceeds anything that physicians are used to or are aware that they're required to do, and I think they have been great partners in sending that message. Our congressional delegation in Massachusetts has been highly engaged on this issue, raising questions with CMS about the degree of medical review, as well as the consistency of medical review that we have seen in the last 2 or 3 years in Massachusetts and New England, especially even compared to other regions of the country. I think there have been some indications to us that we are beginning to see a decrease in volume, but we would love to hear from you what your experience is, not necessarily today, but by emailing me or Colleen directly. And many of you have assisted us with that congressional education. We appreciate that. We've supported NAC's efforts, the National Association for Home Care, to keep the lawsuit on face-to-face from being tossed out of the courts by providing them data on what's happening in the Northeast, again, particularly around the lack of education for physicians and how that is impacting payment for home care. At the end of the last congressional session, before they convened after Christmas time, we and a few states pushed legislation that would have mitigated the language in the face-to-face law that would set compliance standard as simply a date and signature by a physician that there had been a face-to-face encounter, eliminating the narrative altogether. That legislation was not successful, but Congress is coming back into session, and we will begin those efforts again. None of that mitigates the need right now to comply with this rule as it exists, so I'm going to turn the program over to Colleen, who will walk us through. We do want this to be interactive, but for purposes of this webinar, we have phone lines muted, and people can text questions in during the presentation, and we will try to get to them as you send them. So with that, I'll turn the program over to Colleen Bayard.
Thank you, Pat. And thank you for everyone for joining in today. I hope this will clarify some of the questions that you have. And during the presentation, if you do have questions, please, we can't open up the lines. Your lines are all muted, so just type them in as we go along. So for the agenda today, I'd like to start with talking about the regulation changes as of 2015 to focus on those. And then just to reference the eligibility, so you can use these following slides if you needed to speak to a physician or explain something about eligibility or the homebound. And we are using the new criteria that has come from the manual of the spring of 2014. And we'll just talk about what is needed to comply with this new regulation, what the Home Health Agency needs. And then also, Megan sent out with this PowerPoint 2 other handouts. One is called an Addendum to Certification for Home Health Services, and that is a document that the Home Care Alliance has developed to assist with this new regulation, so I will be referring to that. And then the other one is a tool trying to help you to guide yourself in the many scenarios of face-to-face and certifications, both by PCP or by the hospitalist. So we're hoping that will help, and we'll go over that in detail as the presentation moves on. And then finally, just what happens if the certification is not met. So I just wanted to share this with you. I thought this was interesting. I was on another webinar given by Dr. Stephen Landers, the President and CEO of the Visiting Nurse Association of Health Group. And he actually pointed out that in the section that is in regards to the face-to-face for home care, which is section 6407A, that there are only 30 words that pertain to the home health certification. And here CMS has used in excess of 30,000 words, rules and regulations, and we still don't understand this. So I think that just speaks to itself. So what has actually changed? What has changed is that CMS is putting the responsibility of this onto the physician's documentation. And that documentation now has to be housed in the physician's medical record, or if the patient's coming out of the acute or post-acute, it would be in the facility's medical record. Also, whatever documentation is in those medical records, a copy of that must be provided to the home health agency to show that the patient has been eligible for the Medicare home health benefit. So after those 2 points, if an agency sees that the documentation they feel is not sufficient for compliance, so for example, the homebound status is not documented clearly, then the new regulation does allow a home health agency to complement the physician's documentation by incorporating whatever the home health agency writes into the physician's medical record. And that would be done by the physician reviewing and signing off, would be saying that he has incorporated it into the patient's chart, and then the home health agency would receive a copy. Now, between you and I, if he's supposed to keep a copy, but if he doesn't, you have the copy, and that's the main point. So those are the 3 main areas that the regulation has changed. Just to go over the certification, because I know, and I had heard this from, I was at Mass Hospital Association, folks get confused a little bit. So this is just to, I cited the regulation for you. We all know the 5 points of certification, but I thought I would just put this for your ease in this document. And hopefully the area that the physician really doesn't document as sufficiently seems to be the skilled need and in the patient's homebound status. Also to use as a guide for yourself is the definition of confined to home, as Medicare classifies that. And they changed it to have 2 criteria. In the first criteria, one of either of those bullets need to be met. So the patient has an illness or injury and they're requiring assistance of another, or there's a medical condition that could be causing them to have to stay at home. So at least one of those has to be met, but in the second criteria, they both have to be met. So there must be exist a normal inability to leave the home, as well as the documentation that is a considerable and taxing effort. I have some questions about this from the Mass Hospital Association, so I thought I would just point this out. They had questions if the patients did leave the home, then they were on homebound, and we all know that's not true. This is directly from the Medicare Home Health Manual, that they can go out for certain periods of time for certain reasons. It's very infrequent, and these are, as I said, listed in the Medicare Manual. So what is needed now? What we need is that the certifying physician, or if it's the post-acute or acute facility's medical record, really have to justify the referral for home health. And so in that referral, whether it be the clinical progress note or the discharge summary, Medicare isn't saying exactly where it has to be, but the physician needs to show that the patient is homebound, as well as the need for skilled services. And then the actual clinical note of the face-to-face, that has to be signed and dated. And what hasn't changed, of course, are the time frames. You still have to have the 90 days before or the 30 days after the home care start of care. It still needs to be related to the primary reason the patient needs the home care services. And, of course, performed by an allowed provider type. So, again, this is another slide for your reference. I've cited the regulation at the bottom, but these are the allowed provider types. So, of course, you have the certifying physician, the PCP, of the physician in the hospital can certify, do the face-to-face, a nurse practitioner, or a clinical nurse specialist, certified nurse, midwife, or physician's assistant. Again, that hasn't changed. But to certify the home health benefit, it must be a physician. So Medicare defines that physician, as we all know, as either a doctor of medicine, a doctor of osteopathy, or a doctor of podiatric medicine. So if someone says to you that a nurse practitioner has just certified home health, that is not acceptable. It has to be a physician. And it cannot be a physician's assistant. It has to be one of these three to do the certification for those 5 criteria that were on the previous slide. So what the home health agency needs, what we need is that documentation from the physician or from the post-acute hospital. And I'm sure that's where your difficulty lies. As Pat said, we stressed this point on the Mass Hospital Association. We had a webinar for physicians as well as discharge planners. And we explained to them that they would have to give a copy to the home health agency. Someone just asked a question if the certifying physician has to be PCOS enrolled. Yes, they do have to be PCOS enrolled. And so for this information, you know, as I said, and we've asked questions to CMS, they're not dictating where it is in the record. It just says it has to be in the record. So it could be a clinical note. Some people call it progress notes. It could be on a discharge summary, any of those locations. And as you probably are well aware, CMS is proposing to do a template for this as well, and we'll just discuss that a little bit at the end of the presentation. So what's different about this regulation, and I think this is really a very difficult thing for folks to do because it is very confusing. Again, I'm going back to that 35,000 words to try to figure this out. But CMS has said as of January 1st that a home health agency can now give information that can be incorporated into the physician's record of the acute care post-acute medical record. But that is just complementing the physician's information. It isn't the only thing. The old face-to-face that we all know and, I don't want to say love, but the form we know cannot stand alone. There has to be documentation in the physician's or hospital's chart. So whatever information that you do give the physician, you would have to acknowledge who in your agency had completed that. So a clinician would need to sign and date that they had completed that. And as well, the physician needs to review and sign off. He's actually saying, yes, I agree with this, and I am signing and dating it. And literally, this last bullet of this slide, I lifted from the CMS webinar that was held on December 13th. So now, because this is so confusing and I get so many questions all the time, and I see them on national listservs as well, the Home Care Alliance decided to do 2 things to try to help our members. One, we developed an addendum for certification for home health, which we believe would really help you to zero in on the homebound assessment And there is also another document, I think, to be used as a tool. It's called a Guide to Compliance with the Face-to-Face. So for this guide and for the rest of the presentation, I want to point out, because I want to make it clear that even though we're giving you some other tools to use, the main point from CMS is that it is the physician's responsibility to provide this documentation. And then only if a home health agency feels it's not sufficient to support the certification, and usually, as I said, that's homebound and skill, then the home health agency may provide the information to the physician. But that has to be signed and dated. Someone's actually asking me a question. The question is, could we report the clinician making the assessment of skilled and homebound without having the clinician sign? I would have to say no. Where would that come from? Someone's actually documenting an assessment somehow of why they're homebound and the skill. And I could see Medicare reviewing that, saying, well, who did that documentation? And I would certainly think if a physician wants to sign as well, that physician would also want to know who has done that documentation. Thank you for the question. This is a good one. So the next slide. So for the options for these next few slides, I'm just going to, so you know what form that I'm talking about. This is the form that I'm going to be referring to. So maybe you could take notes on this. But we thought this might be a tool that you can use for the different scenarios. And we've noted at the top, because there was some confusion with the Mass Hospital Association folks, they actually thought that us documenting could be good enough and nothing really would be in the medical chart, and that is not true. So it is the physician's responsibility, as the Home Care Alliance wrote this at the top, to provide the documentation to substantiate that. And if you think it's not sufficient, then the home health agency may provide information that can be corroborated and incorporated into the certifying physician or post-acute facilities medical record. So that notation stands for all of these documents throughout the rest of the presentation. And as you can see in the tool, there is option 1, which is the face-to-face and certification both by the PCP, and then there's 3 options to that. And then the face-to-face certification, the face-to-face as well as the certification is done by the hospitalist. And then the last option will be that the face-to-face is performed by the hospitalist, but the certification is performed by the PCP. So I just wanted to point that document out to you. The other document is so you can have it ready when we turn to discuss it. It's the Addendum certification for home health, and this is what that document looks like. So back to the PowerPoint. As I just said, these are the 3 options that we have, and I'm going to enlarge the screen. Thank you, Megan. Megan's helping me maneuver through this. I have her PC in front of me. I apologize for that. So these are 3 scenarios that we're going to discuss. So the first is when, I'm going to say, this is the old-fashioned way, I guess. The patient goes to the doctor for something, open draining wound, whatever, and the doctor calls our office. So the primary care is doing the face-to-face and all of the documentation. So this is option 1. This is what CMS wants to happen. This is what they're trying to strive for. And as we all know, I'm not sure how much this happens, but this is what one scenario would be. The physician does it all, and he gives you the record, a progress note or a clinical note. And in that note, it says what the need for skill is, why this homebound. He says he's ordering home health. You see there's an encounter that has been dated and signed. as well as if it was performed, it had to be performed by one of the appropriate provider types. The next one is for the physician. Again, he's be doing this, but you look and you see that his record is not good enough. So you want to use the face-to-face form, and I'm going to call it the traditional one, or the old one, the one that we all know. And I know a lot of folks are still using that. However, if you are using that, I would recommend that you would need to modify that. If you are filling this out and you are listing why there's a skill and all of the homebound, I really think that that clinician needs to sign who is documenting this information. As well as, because you need to incorporate this into the physician's chart, you need to have a statement on there that would say that the physician is acknowledging and incorporating it into his chart, and he would be signing and dating it and then giving you a copy. And then the third scenario for this is that with physician's progress note, you decide not to use that traditional face-to-face, and you decide to use the addendum that the Home Care Alliance developed. So I will switch back to that addendum so we can take a look at it. And I want to get this to one screen, but I'm struggling here. Sorry. Thank you. Thank you. Okay. So on this form, and I'll tell you, Pat actually had sent this to some higher-ups in CMS and asked if this would be appropriate, if we could use it. She asked multiple times, and we never heard back. We weren't asking for them to certify this form and saying it was perfect, but we were just looking for an acknowledgement that this would suffice for the compliance. But unfortunately, that was not returned or answered. I said our questions were not answered. So with the addendum, the patient name, of course, date of birth, you would, if you know the encounter date, the physician's told you, your home care clinician would be completing either criterion 1, either one of those parts, whichever is appropriate for the patient, and then completing both sections for criteria 2. And the reason we did this is because there was so much difficulty with homebound was insufficient over the past few years. We decided that it would be appropriate to literally take what Medicare had sent to us and try to put it into a format that would be reasonable for folks to fill out. And then the skilled services would be next, and you could elaborate on that. The physician prints and signs the name, the date they're assessing. And then the statement is saying that they're certifying home health and that the physician's signature indicates review and incorporation into the patient's medical record. And then a signed copy would be sent to. And you would use this form. You put your own letterhead there, your name and address, and you can get rid of that. You could, if you decide to use it, put your letterhead on it, change it the way that would work best for your agency. So you don't have to fill that out each and every time. And then if you're looking at this right now and you're looking at the copy that Megan sent you, you're going to see it looks a little bit different, and we're going to go over this in a little bit more detail at the end. But if this is from a hospitalist, it'd be a check mark, and I'll go over that when we get to those slides. And if this is for PCP, they would be saying, which you do not have on yours, it says, I acknowledge that there was a face-to-face encounter on, and you would say February 17th, and it was performed by Dr. Smith at the Brigham and Women or something. So we decided to add that, and you'll see the rationale for us adding that when we get later into the presentation. So back to the PowerPoint. Okay. So I pretty much just explained that addendum, and yes, I did explain all of that. So the next option that could happen would be that the face-to-face and the certification are done by the hospitalist. And I think this does happen quite a bit in Massachusetts. You know, I know a lot of folks tell me that the doctor will sign a face-to-face and certify, and then they transfer it off to the community physician. So if indeed that's a scenario that happens to your agency a lot, again, this can be in progress notes, discharge summaries, pardon me, whatever the hospital names those types of forms that they would give you. I'm kind of repeating, but you would need some skilled service, to document the need for skilled services. Homebound, again, it would be an order for home health that would be documented in the discharge summary. The date would be signed and dated, of course, for the encounter, and this hasn't changed. It still has to be an allowed provider type. But in that documentation, and I'm not always sure that that's there in the discharge summary, it would have to have some sort of a statement that would say it would be followed by a community physician. So if that is the case, please check that documentation is there. We did contact CMS, and they said that when a hospitalist is certifying, he does need to acknowledge that the community physician will be following. The second scenario is you have the hospital record again, and it's still the hospitalist certifying, and you decide to use your face-to-face form, which, again, you need to modify. You need to say who the clinician is who's signing and documenting, why is there a skill, and why is the patient is homebound. But you would also need to modify your form to not only say that the physician would sign, and he's incorporating it into the medical record, but you also would need to add a phrase for this particular scenario to say that the care was being followed by a community physician. So a face-to-face cannot stand all alone. There has to be other documentation from the hospitalist regarding the certification process. And then finally, the other option would be, again, use the hospital form, discharge summary and whatnot, and our addendum, that form I showed you a few minutes ago, to the certification for home care is just complementing the physician's note. And on our form already, it does say that the physician is referring to a community physician, and all the acknowledgments are already there, so that form doesn't need to be altered. And at the bottom of the form, and I just took a little screenshot of it, there's a space under the certification for the need for home health, and it says for hospitalist only, and the hospitalist would check there. And by the physician checking that, he's saying that it's passing off to the community physician. And then, of course, the physician signs and dates, and hopefully they keep a copy and you get a copy. The last scenario, again, there's 3 options in this, and you'll see as we go through it, it's very similar to what we've just discussed. But this does happen sometimes, and I can see this being a little problematic for folks. So this is when the face-to-face occurs in the hospital. But that hospitalist doesn't want to certify. He's just saying he did the face-to-face encounter, and your documentation might not be that good, and he won't certify. So in these next 3 scenarios, and that's why I put an asterisk and put it in red as well, and it also is on the tool that I used, I put it in red. For this to meet compliance, the physician somehow has to document either in a clinical progress note or document a phone call that he's had with the hospitalist, or signing off on a discharge summary that he acknowledges the face-to-face. Somewhere in that physician's record, there has to be acknowledgement of a face-to-face that was done by the hospitalist. And I understand that happens quite a bit, that could happen. And in that case, then, the physician in his notes somewhere he's sending you, he's talking about, yes, I'm going to order therapy, the patient's confined to home, the services, Of course, they'd be under the care of the PCP now. And the face-to-face would be the hospitalist. You also, and I'm sure you could see that the homebound status may not be well documented in a scenario like this, and again, you could use your face-to-face form. Again, as I said before, for the exact same reasons, you would need to modify to include clinician information, and then an acknowledgement for the physician to sign off that he is he reviewed it, acknowledges it, and he is signing it and putting it into his chart. And then finally, it's the same addendum to the certification. And we did, I'm going to actually escape out of this for 1 minute. Let me see here. We did alter this a little bit to help with this. So this is the addendum to, let me just scroll up so you see the front of the page. This is the addendum to certification. This is not on your copy. We will send this out to you after the webinar. I do apologize, I sent you the wrong one. But as you can see, in the lower quarter of this page, we also added for PCP only. So this is the scenario where the hospitalist did the face-to-face. The doctor is checking off and acknowledging that the face-to-face encounter was done on whatever date and then was performed by the name of the physician in whatever hospital is. And then he would sign and date off on that. And then so back to the PowerPoint. Okay. I do have a couple of questions. Let me see, I'll stop for that. I'm not sure, right? Can you read that to me? What's the first one? Yeah. QI takes it from the record and transfers it to the form. So we do have a question, and I'm going to ask that person to please clarify a little bit. I'm not sure it all came out on our screen. It says if QI takes it from the record and transfers it to the form. You might have said that when I was talking, and I didn't see it up on my screen, so I apologize. So I kind of lost the context that you're in. So if I may ask that person to please be a little bit more specific, and I'll try to answer that. It says, what if home health agency does not have access to the MD's record? Well, I mean, you have to request that documentation. And actually, this is an appropriate question for the slide that is up right here. And feel free to share this regulation with your PCP. The Mass Hospital Association is acutely aware of this. They have told all of their providers that if a physician does not comply, or they don't give you the records, or if the records are inadequate or they're incomplete, and CMS saw that that was a particular physician, they could be actually subject to increased reviews and actually a provider-specific probe. That is stated in the regulation. It has gone out in a recent MedLearn Matter. I think it's SC 1436. I'll confirm that with you. But also it's stated in that, and that's just for physicians, so you could reference that to them. But they need to, I think if you get a referral, what I'd probably do is when the referral's coming in or coming from the patient's PCP, I would ask them if you could have a copy of the physician's progress note of the patient's visit that day. I think we're all going to have to do it, and at first they might buck a little bit, but I mean, you need it. So I think it's best to get it up front. You know, someone has said to me, I'm just going to wait till I get audited. But if you get audited 2 years from now and you're trying to find that record, I'm not sure that's a good policy. But we're getting some questions coming in. Okay, so So the question is, we were thinking that QI could copy from the home care record and put the assessment date on the addendum to certification. They don't do the assessment, but they are taking it from the specific clinician assessment. Oh, taking info from the specific clinician assessment. If you're doing that, I'm still thinking that you would have to have somebody sign that. Someone has to be responsible for what's written on that form. And maybe if you know, it's really a good question. I'm not 100% sure of that answer. I mean, I think it would be okay, but I really don't know. I'm going to table that and see if I'll try asking CMS again. But I don't want to give you an inappropriate answer. I'm really not sure. So someone is asking me, who is considered to be the clinician on the addendum handout? Is it the admitting clinician, or can a QI person take info from the record and fill it in form? Oh, that's pretty much the same question asked again. I'm thinking it's okay to have the QI person because they're a clinician, they're signing, they're acknowledging it, they read it from someplace else, but Medicare is so particular that I'm really not 100% sure. So I will look into that. Okay. Thanks for those. Those are really good questions. I'm sure you're all familiar with this. CMS, I just wanted to bring it to your attention. CMS has proposed a template for the face-to-face. They came out with it on January 29th. Here is the website on your PowerPoint. If you click it, it'll take you there. And it is for public comment right now. It's not going to be mandatory. It's going to be a voluntary thing that physicians would use. There is a paper copy as well as an electronic copy. And back on February 11th, they had a special open door forum. I don't know how many of you folks listened to it, but I did, and I had more questions coming out of that than I had going into it. I have sent the, so the comments can be sent, this is on your screen, to the email address of homehealthtemplate@cms.hhs.gov. And I sent them in a few questions. I'm not sure when how they're going to get back to me, or if I just have to wait for the next open door forum. But when you look at their proposed copy in section B, they're saying when you go to the end of section B that no person from a home health agency could fill this out. And so my question would be, what form are they, or if they are using this form in a hospital situation? I can see this in a doctor's office, but if this was in a hospital, I don't see why a discharge planner couldn't fill it out, could possibly a liaison fill it out. They're evaluating the patient. If they did and could answer these questions so much more efficiently for a smooth transition for this patient. So I did ask that question. And I asked quite a few other questions, not necessarily about this particular form, but just about the operations of what we can and what we can't do. I'm not sure they'll answer them, but you know, we tried. But if you do have any comments, please feel free to address it at this this email site. The next open door forum is scheduled for March 11th, and I will send out the call-in information when I do get it. I have another question. Can a home health agency use the 485 as a tool to inform the physician of the need for skilled and homebound status, etc.? That's a really good question, and I'm going to tell you I don't know. I have asked that of CMS myself. They have not answered me back. I'm thinking if you did do that, then you would have to say somewhere in there, you know, I am certifying, add another statement, and I am incorporating this into my medical record. Because Pat and I had a conference call, actually quite a few months back, with quite a few physicians in CMS, and the physicians who were on that call told us that they do not keep a copy of the 485 in their chart. And it was like, oh boy. Okay, you don't keep a copy. So they say, no, we just sign it and then mail it back. So because I know that, I think you'd have to modify the 485 or in locator, what is it, 19, the service, or 21, I don't know, I don't have the 485 in front of me, but where you write the skilled services, under all of that section, I probably would add that statement that his signature on this form indicates review and incorporation into the patient's medical record. The next question is, if the hospital certifies for home health, then does the hospitalist have to sign the addendum rather than the PCP who signs the plan of care? Yes, it has to be the hospitalist, because the hospitalist is the one certifying. And the form that we have is the addendum to the certification. The PCP is following the patient in the community and turning, and it's really just involved with the plan of care at this point. So again, it's yes, the hospitalist would have to sign the addendum to the certification. We did show this form to Mass Hospital Association as well, that possibly they could be getting it. So it's not a foreign form to them. You know, they were honest with us. You know, you putting a piece of paper into our chart kind of is easier said than done, although I did hear from some discharge planners that they actually copied the, I'm going to call it our old face-to-face, and actually put it into the medical chart. So some of the discharge planners who were on the calls and the webinars that we had said that they would try to do that. You know, I guess it depends upon the hospital that you're at.
Colleen, this is Pat. On that issue, I mean, the question, the idea is that the documentation coming from the hospital and the hospitalist, supplemented by the case management, if that information is sufficient to document skilled and homebound status, then you do not need the addendum. The goal is to have the documentation coming from the hospital have all the certifications that we need, and that's a lot of the education that we're working on. I mean, I think what you were saying, Colleen, is because all of it does not have to be completed by the hospitalist itself, a case manager at a hospital could add information to what is coming to the home health agency. As long as that has been signed and incorporated into the record, then again, the discharge note, the discharge plan with the case manager's supplement, an addendum, if they use this form or something, which is signed off on. If that is sufficient, you don't need the addendum or anything else to be completed by home care. Is that correct, Colleen? That's what we are talking to the hospitals about. Trying to get between the hospitalist and the case management departments for them to eventually be sending us documentation that's complete. Now, we know the documentation sufficiency standard has been subject to a lot of interpretation, but the goal would be to use the addendum as the exception when that documentation isn't complete. And we know we have a long way to go to get there, but that's what we're working toward.
Right. Thank you. I do have another question. The question is, please clarify what you mean by the modified face-to-face form versus the addendum to certification developed by the Home Care Alliance. Why do we need both? You don't need both. If you look at the tool that I sent, those columns signify different options that you have. So if you just want to use your face-to-face form, you just use your face-to-face form and then you don't use our addendum. The only reason why we developed the addendum was, you know, a different choice. It's a new rule. It's a new form. We thought it was concise, but you do not use both. No, absolutely not. It's one or the other. if, like Pat said, if you find that the documentation from the physician isn't good enough, and, you know, like Pat said, we really have been striving to say that we, the home health agencies, shouldn't be giving you information. You, as best you can, have all of this information in your charts. And the discharge planners at Mass Hospital Association were actually very open, and they said they would try to, you know, increase the documentation, make sure the physician did it in the discharge summary, and they had a similar PowerPoint, although it was for Mass Hospital Association. It was geared truly just to them. There was no information really about the PCP.
And then, Pat, on that issue, I'd like to support what Colleen said, is one of the reasons we thought with the work group we have had here, a small group looking at the changes between 2015 and 2014. In 2014, the face-to-face form that people were using, as you all recall, the regulation was that all of the information on that had to be completed by the physician. So that was a form essentially that we were not completing in any way, shape, or form. The reason we went in our education to using an addendum is exactly what Colleen said, to say now this is something that can be completed by a home health agency or a case manager to supplement what the physician has done. So it gets to the heart of the change in between 2014 and 15. That old form always had to be completed in the physician's own hand. Now that we have the added ability to supplement, we wanted to use a different type of form, if you will, to make that distinction. And again, as Colleen said, if you want to use that, but suddenly now you are completing that as an addendum to what they give you, it's fine. But what we were trying to make is the point that in 2014, what people were used to as a form that only had to be done by physicians, now that rule, that regulation does not exist in that way. The physician does not have to complete everything. We can addend to it.
Thanks, Pat. Just to wrap up, folks, I put a resource here for you that if a physician was giving you a difficult time or not understanding it, it might be helpful for you. So if you actually put into your internet browser S as in Sam, E as in Edward, 1436, and also type in the word revised, this should really pop right up. It's called Certifying Patients for the Medicare Home Health Benefit. I think it's like a 10, 11-page document that is the Medicare Learning Network matters, and all of this is explained to them with the new guidelines. And then the next resource is the face-to-face template, the proposed template. I put that website in as well. I do have another question. We have a little time left. Can you repeat the 485 scenario, when it would be appropriate to use this? I guess when I'm, oh, wait a minute, addendum and send, oh, no, it's a different person. So when you would use the 485, someone asked above that could they put the homebound and the skilled services on the 485? Well, that is really already on the 485 as we know it. What I was saying is if you do that, I would recommend that you put a statement on there saying that the doctor is in agreement with this and that he is going to incorporate this into his chart, his or her chart. I can't tell you if that is good enough because I am not sure. I have asked it multiple times to CMS if that would meet compliance, and they have failed to answer that question. So that's where my hesitation lies. Because we've always used that form, I'm not sure why CMS would just accept it again or accept it with this new regulation. I'm going to be honest with you, I don't know, and I'm sorry.
And to add to that, I mean, just so folks know, I mean, I think folks may or may not know this on the call, CMS does not recognize the 485 as an official Medicare form. And they do not recognize that as an approved form in general. We have used that as the plan of care, and it has become to be standard of practice in use in home care. But when you say to CMS, the 485, they will say that is not a form that we recognize or have approved for use in any way, shape, or form. It's difficult to understand that. So when we are talking to CMS and officials about what home care should have in the record versus what the hospital has provided versus what the physician has provided, we often talk about the home care plan of care and what can be on that versus the physician's progress note or the hospital's discharge summary. Because whenever you say 485 in a meeting with CMS officials, they say we do not know or recognize the 485. So just for folks who may not know the history of that, right, that's where we are now. So whenever we are asking questions about what needs to be there, we always say on the home health plan of care, can we document this, what signatures need to be there? Because that form is no longer recognized by CMS.
Right. I do have another question, and it's going back to the 485 / plan of care, because Medicare slaps our hands when we say that. The question is, could a home health agency fill in the addendum and send to the PCP with the 485, which is the certification? The overlying issue to this whole regulation change is that this documentation has to be done by the physician. He has to certify in his record all of those 5 points that was on one of my first slides, homebound, skilled, that all has to be done by the physician. You're just adding a little bit if you think it's insufficient. So for me to say, yes, you can just put that on a 485 and yes, it's certification. If that's not in his medical record, these points, and it is just the traditional 485 / plan of care form that we've always used, I would think that an auditor would have an issue with that. I would be uncomfortable with that. And we've been emailing back and forth with some officials in CMS, and every time we ask a question, they will say back, it is the sole responsibility of the physician. It's only the home health agency complimenting on something that may be off. So for us to do the majority of the documentation, I would think would be an area that they might scrutinize closely. The next question is, when making the initial call to the MD, can a clinician include in the call log that the MD is in agreement, and then can they make an interim order, I think, stating the same? Let me read that again. If making the initial call to the MD and a clinician include in the call log that the MD is in agreement, and then can we use that in an interim order? So I think what you're saying, I'm not sure, you may have to email me back. I think you're saying that a physician, a PCP has called you, and you have some documentation from him, and you've spoken to him directly, and the documentation isn't good enough. And so you're putting this in whatever document you call it, and I'm assuming then what you're saying by it's an order, that you're sending it back to him and getting it signed. I guess my question back to you is, what do you have from him? What documentation of that physician do you have? Because you need something. And just phone calls back and forth without you having a physician's medical record or part of that medical record would be out of compliance. So if I'm not answering what you're saying directly, please feel free to ask again, or if the presentation finishes by then and you want to email me later if I didn't answer you, please do so. Thank you. You're welcome. Do I have another one? Yes. Okay. So the next question is, if a face-to-face form has all the elements needed and is specific in the skilled need and the homebound status, is the face-to-face form documentation sufficient? No. Or do we need an additional document of skill and homebound in the physician's notes as well? Let me go back, and there's probably, I'm saying it if you look at the first slide. It is the sole responsibility of the physician to document in his or her chart. You need something from them. So they have to allude to, there's a skilled nursing for an open draining wound, if they need physical therapy because they need gait training and modifications of the home environment or whatever that may be. And then the doctor would say that the patient is homebound, and maybe the doctor says because he's using a walker, and they're talking about he's going to see the patient and all of that. But you say, oh, that homebound isn't good enough. Then your face-to-face form with all of that information is good documentation and will help. But it cannot stand alone. I've asked this with Medicare. A face-to-face, and I'm putting that in quotation marks. I know you can't see it, as we used to know it and know it now, would not meet an audit. You need something from the physician.
And this is Pat. The original face-to-face rule always said that whenever the person saw this physician, whether it's a hospitalist or a physician in the community prior to or within the time frame of being referred for home care, that the visit to the physician or the time spent with that physician or hospitalist had to be for the reason the referral for home care, at least in part, was being made. So in other words, you couldn't say, oh, they saw a physician 20 days ago for this, but now they're being referred for home care for why. The visit to the physician and what the physician has documented has to be related to the condition or the treatment for which they were referring them to home care. So just saying, oh, they saw a doctor within the time frame, but that doctor was not related to what the complaint they're now sending to home care to address, doesn't cut it. The physician, always the face-to-face visit had to be related in some way, shape, or form to the reason for the referral for home care. Ergo, the idea that somewhere in the physician's notes there is information that indicates why they sent them to a home care agency in the first place.
Okay, there's another question. Can you scroll up? Did I miss that one?
No, that was one.
Oh, that was one. Okay, I'm sorry. So the next question is, if there was an encounter and everything is present to certify, does the encounter date have to be documented somewhere? Well, yes. I mean, it would have, if you need that date of the face-to-face on a physician's notation, that has to be there. If it's not there, and then you just I don't know how you're finding out the date, but the doctor would have to write that date of the face-to-face. The next question is, if the discharge summary and the face-to-face encounter is completed by a PA or nurse practitioner, could that clinician fill out the addendum form, and then the MD could sign and certify that bottom section of the addendum form? So I think what I'm understanding is that a nurse practitioner in a doctor's office saw the patient, and the nurse practitioner is using this form, the Home Care Alliance's form. I think that's what you're asking me. And then that physician's assistant is filling out those two things. And then what you're asking is, in the certifying physician, let's say the PCP signs the bottom. Yes. However, there needs to be other documentation in the hospital. This is saying it's an addendum to something that's already been written by that physician. So, you know, these documents, even though we're trying to be helpful, they can't stand alone. And if you look at the template from CMS, you know, they're very particular. They're even saying, you know, home health agencies can't fill any of this out, and it's a very lengthy form. So I would think that you clearly, as the regulation says, you need to have something from the physician in the hospital or from the PCP's medical record. Someone has asked a question. That's a great question. How will the home health agency know if the physician has kept the required documentation in his or her records? I have no idea. And I wouldn't worry about it. If he's saying, and he has his signature on that, and as we document it, a signed copy will be sent to you, that's meaning that he was supposed to do it. If he or she didn't do it, I hate to say it's not my problem, but that's it. Okay. I think that's it. There's no more questions. I really appreciate everyone listening in. As I get any updates from Medicare, I will be sure to pass them on to you, or if there are any significant updates, we could do another webinar. If you have other questions, please don't hesitate to email me. I'd be happy to answer them for you. And, you know, there's a lot of different scenarios of this hospital does it this way and this physician does it that way, and it's very confusing. And, you know, I understand the frustration that this must be causing for everyone. So thank you for listening in.
Thank you, Colleen. Thank you, everyone. And always you can send questions to the Home Care Alliance. And as Colleen has said several times, given the limited guidance we have so far, we're doing our best to answer those that we can.
And there's my contact information if you don't have it. Thank you, everyone.